7 p.m. Okay. All right, good evening, everyone. It is now 7 p.m. and welcome to Coronavirus and COVID-19 and Us. Coronavirus, COVID-19 and Us, the EmPower Hour. We thank you for being here this evening. We have a great panel that will be joining us. We have one of our panelists who's already shown up, and we are awaiting the other panelists, and I'm sure they will be here soon. So again, I want to thank everyone. This is our 4th EmPower Hour. We've just had some tremendous guests for the first 3 EmPower Hours. We have had David Williams, Harvard University. We've had Reuben Warren down at Tuskegee University. We've had several MDs, OBGYNs. We've had family physicians. We have had college professors. The list goes on and on and on. And we are fortunate this evening as we have this conversation and we cast a broader net. We've looked at communities, African-American communities. We've talked about Latino communities. And now we want our conversation to sort of bring in the LGBTQ community. And we are so fortunate to have individuals who are with us this evening that's going to help us understand the organizing efforts of that particular community. We also have online with us soon 2 physicians this evening. Dr. Tracy Nelson, she's in Myrtle Beach, South Carolina. She's an OBGYN. And then we also have Dr. Harold Moore, who's family medicine here in Decatur, Georgia. And then we're also waiting for another gentleman, Damian Lima, who is in Boston, and he's going to be sharing with us as soon as we're able to get him online. So in the meantime, we want to thank everybody for showing up. Great seeing everybody this evening. Always a pleasure seeing everyone. And everyone knows how we do our chat. Everyone knows how we do our chat. Please ask your questions in the chat. Greetings, everyone. Please ask your questions in the chat, or you can hold your questions and ask them yourself. We always start off our conversation by allowing the panelists to share with the audience. I'll give a brief introduction as to who they are. Then they'll talk about their efforts from their particular viewpoint as far as what's going on with their particular community, their particular cause, their particular perspective regarding coronavirus and COVID-19. So we also use the chat area, as I mentioned, to ask questions. Keep questions brief. I'm multitasking. And so oftentimes I know there's a lot of you academics out there, you'll ask this question and it'll be about as long as my arm. I don't have time to read a question that long. Keep your questions brief. And then also when we open it up to the Q&A part, if you decide to ask your question briefly. So brief in the chat, brief if you decide to want to ask the question personally. So again, I want to thank everyone. Obviously, we're dealing with a serious issue here with coronavirus, with COVID-19. We're hearing of the deaths. We're hearing of the malaise. And we have another guest who's just coming in, Dr. Harold Moore. So we've heard of all of the negative, what's going on with COVID-19. And out of this, we have to figure out some of the positive. We just have to figure it out. And so that's why we hold the EmPower Hour. How is it that we can help each one of you, all the participants, gather more information that you can put in your quiver, that you can put in your arsenal. So when necessary, you can pull that arrow out and shoot it, if I can use that analogy, and use it, not necessarily shoot it, but use it whenever possible, because again, we want to make sure that we're safe, that we're healthy, and that we're all staying at home. So with that, we want to go ahead and shift gears. And again, Dr. Moore is trying to get in. I see that I've allowed him to come in, so he'll be in a second. But we're going to go ahead and start our panel because again, it is a few minutes after 7. I just want to thank everyone again for being here this evening as we move into our 4th EmPower Hour. So thank you. Have your questions ready for our panelists, and we're going to go ahead and get things started. So I first want to introduce Casey Pick, Attorney Casey Pick. Casey is with the Trevor Project out of Washington, D.C., which is also based in Los Angeles, California. I'm thankful to Attorney Pick for being here this evening. Sort of short notice, but that's how this thing goes. We put out the call, and Attorney Pick was able to answer that call by being with us. So I am grateful that Attorney Pick is here. Casey will share with us what's going on with the LGBTQT community and their response to coronavirus, to COVID-19, the coping mechanisms for young people who identify LGBTQT, and all of what's going on with them. Casey attended Claremont McKenna for undergraduate, went to UCLA for law school, and we're just so gracious that she's with us. And a lot of her work has been shared with national outlets, national media outlets, and we're just so appreciative that Attorney Pick is sharing of her time to be here this evening. So Attorney Pick, please, can you tell us about the Trevor Project and what it is that you do as the Senior Fellow for the Trevor Project in Government Advocacy, please?
Absolutely. Thank you so much for having me. I chuckle a little bit that my first name has become attorney. That is in some ways, it's an important part of what I do, but it's not all of it. So the Trevor Project is the world's largest provider of suicide prevention and crisis intervention services for LGBTQ young people. We work to save young lives by providing support through free and confidential suicide prevention and crisis intervention programs on all the platforms where young people spend their time. A 24/7 phone lifeline, chat and text services. We also run our own social media space called Trevor Space, which is a safe space social networking site for LGBTQ youth. And we operate education, research, and advocacy programs. So just a little bit of background on why Trevor exists. We know that suicide is actually the second leading cause of death among young people, and lesbian, gay, bisexual, and trans youth are actually more than 4 times more likely to attempt suicide than their peers. So LGBT youth from highly rejecting families are 8 times more likely to attempt suicide than youth from accepting families. And at Trevor, we estimate more than 1.1 million youth between the ages of 13 and 24 seriously consider suicide each year and could benefit from our services. So what does that mean with regards to the COVID-19 crisis? For us, it means that in the course of since the quarantine and the epidemic began, the volume of youth reaching out to our crisis services has more than doubled. And mentions of the pandemic have increased more than 60 times in the last month. Youth are reaching out to us with a lot of thoughts and a lot of concerns. Some of the constant themes are feelings of isolation from important parts of their social system, including affirming peers or adults, anxiety about the future, including fear and uncertainty about the safety or reliability of their situations. Many of these youth are being ordered to stay at home in unwelcoming home environments, or finding themselves in a situation where they're coming out and not knowing what that situation is going to look like, or they don't have access to their schools or classmates or usual support network. And of course, we know that LGBT people overall experience poverty at greater rates than the average population. And especially when that intersects with the status of being a person of color, those poverty rates and the insecurity of all of the economic situations we're in today are causing significant amounts of stress. So that's the reason why you saw over 100 LGBT organizations sign on to an open letter earlier this year, raising the concerns about this population and why COVID-19 is a particular threat to LGBTQ people. Some of the concerns that we raised up were that evidence shows that the LGBTQ population uses tobacco at 50% higher than the general population. With COVID-19 being a respiratory illness, that's a major problem. Our population typically has higher rates of HIV and cancer, which also makes us have more likely to have a compromised immune system, leaving us more vulnerable to this particular disease. And of course, LGBTQ people continue to experience discrimination, unwelcoming attitudes, and a lack of understanding from healthcare providers And as a result, many of our population are reluctant to seek out medical care, except in situations that feel urgent, perhaps not even then. So when our people are sick, they may reach out later when the disease is more progressed. And these are some of the reasons why we've taken such pains to encourage government and healthcare leaders, when they respond to this disease, keep in mind the needs of the LGBTQ population. It's not all dark. At Trevor Project, we've been reaching out and making a point of advising on the various different ways that we can support, particularly youth, particularly in the mental health space of this, because we know that a lot of youth are seeing things like the quarantine, and where we're telling them social distancing, they hear social isolation. And that isolation can contribute to feelings of anxiety, depression, sadness, and other just really big feelings. And so we're really glad to see that a lot of those youth are reaching out to resources like Trevor and finding people to provide comfort and advice and just a listening ear. So some of the advice that we recommend and ways that we're trying to encourage youth and also just LGBT people in general is to really be kind to themselves, to recognize that this is a difficult time period for everybody, and that if they're feeling stressors, that is reasonable. And that there are going to be some stressors that are particular to LGBT folks. Think about concerns about a haircut. Now, many of us may not like the fact that we haven't been able to get to a barber for a month. Our style is not what we consider up to our usual standards. But consider for the young transgender man who finds their hair growing out significantly longer than they wanted it to be. And they look at themselves in the mirror and they don't see the young man they know themselves to be because their hair is getting longer. That's what we call increasing gender dysphoria, when what you present to the outside world is not in line with how you see yourself. So that's a particular kind of concern that our population would be facing right now. So going easy on themselves. There's a reason why you see a lot of queer folks who are taking to YouTube and offering up tutorials on how to, cut your own hair. It may be a desperation method, but there it is. So that's just one example of what it looks like to have a concern that is particular to this community, and to just raise up the need for compassion, and at the same time recognize that the queer community as a whole has some things to offer the broader world on this. Not least of which is our history as a community of understanding HIV/AIDS. We have been here and done this when it comes to epidemics and to disease, and we know how to care for each other. And we know that we sometimes need to care outside of traditional family lines in order to make sure that we're taking care of each other. Community means so much. Family of choice means so much. On the one hand, that means that you have more people to worry about. On the other hand, that means that you've got more people to connect with and to support you when you need. And that's one of the things we're really trying to encourage folks, especially if they find themselves at home in a challenging or difficult environment. Or, as we were hearing from a lot of our college youth who were telling us that they were worried that they wouldn't have a home to go back to when their dorms shut down. Take advantage of those families and those communities that you have built up, and that especially the LGBTQ community is so good at doing, of being family to each other when maybe we don't have traditional family. I think that's enough of something just to start with. I'm looking forward to hearing what my fellow panelists have to say. So I look forward to your questions later.
Okay, wonderful. Attorney Pick, thank you so much for that. That was a great overview of what you do at the Trevor Project and for the Trevor Project itself. So thank you for that. And I'm sure that once we open it up to participants, to the audience, that you'll have several questions. So thank you for that overview of the LGBTQT community in response to COVID-19 and coronavirus. And so let's move on. We have two other of our panelists who have shown up, and we're just going to go to them and again allow them to talk about how to what extent coronavirus COVID-19 has impacted their practice. We have both of our physicians here, one who's an OBGYN and one who's family medicine. So we're going to start with Dr. Tracy Nelson, who is in Myrtle Beach, who again can share from a clinical perspective what they've done at their practice in regards to coronavirus and how they sort of put precautions in place to make sure that they're able to deal with their patients sufficiently and efficiently. So we'll start with Dr. Nelson, let her introduce herself. Again, Dr. Nelson is a triple Ivy League. Dr. Nelson went to Dartmouth undergrad, Yale for medical school, and did her residency at Penn. So we're very happy and excited that Dr. Nelson is here with us. So again, Dr. Tracy Nelson, please.
Hello, everyone, and hello to the other panelists. And again, thank you for that wonderful introduction, and thank you for hosting this forum again. I'm not going to keep you too long. What we've done is what I kind of alluded to last time is we are still seeing patients. The obstetrical patients still need to be seen. So we are just screening them, taking their temperature, asking if they've had any travel, if they've had any contact with anybody, or if they've had any respiratory symptoms themselves. Today, for instance, I had to turn away a young lady who had a temperature of 100.7 on 2 different occasions. Sometimes they're sitting in the car and they said they get hot. So what we were able to implement was telehealth. So she got in her car and we instituted the telemedicine video. And basically it's what we're doing right now. I was able to take her symptoms, able to take a history. I didn't necessarily need to examine her. She went to get some lab work done. I could give her a Vicodin prescription, and we accomplished a thoroughly satisfactory appointment without her having to interact with me face to face. Now, regarding tonight's topic, how it impacts the LGBTQ community, you may not know the Academy of Reproductive Medicine, that's kind of like the infertility overseeing body, has recommended that we not pursue any infertility treatments. So I can do a workup, but they have recommended no ovulation induction, and that's to stimulate the ovaries and have somebody super ovulate. So they've recommended no ovulation induction, no intrauterine insemination, both of those that I do, and no in vitro fertilization. A number of my colleagues are really upset by this, and they've written a kind of a rebuttal letter to the Academy, and I haven't heard any outcomes from that. However, this does have a significant impact on the gay community, because if they are either single mothers or same-sex couples who are pursuing ovulation induction or intrauterine insemination, even in vitro fertilization with a donor sperm, all of that has been put to a halt. And for a number of patients, that is a kind of a traumatic thing. If you're 30 or 25, you may have time. If you're 40, 45, 46, or you've already purchased this, then it can put a damper on things. So that is for a certain population, that is quite impactful. And I've had a couple of patients very disappointed that I can't stimulate them anymore, and we're not going to be pursuing intrauterine insemination until some of this corona crisis has kind of resolved.
Okay, Dr. Nelson, thank you for that. And then I'm sure we have many questions, especially given that last piece.
Yeah.
Because that is a major, major concern for those who, like you said, if they're sort of up against the clock,
Yeah.
and telling how long coronavirus is going to be around, the fact that you're not able to do what you need to do to assist them.
It is, and what I forgot to add is the reason they came out with that statement, and this is the first time I've ever seen them come out with this kind of edict, is because we don't know if the coronavirus is going to have any impact on pregnancy. So far, most of the women who've had COVID-19 were in the latter parts of their pregnancy. So they were in the latter part of the 3rd trimester. At that time, usually there's not very many teratogenic or any impact on as far as causing birth defects at that time. We have seen a little bit of an increase in preterm labor, maybe intrauterine growth restriction. It's kind of unclear, but the real question is going to be if contracting COVID-19 in the 1st trimester, when there's a much more likely chance of it having being a source of birth defects. We're waiting to see what the outcomes of those pregnancies. Hopefully it will not be anything, but nobody knows. And that was the reason that they came out with the statement saying, stop intervening. Now, if you get pregnant on your own, that's on you, but we are not supposed to help help you conceive.
Okay, wonderful, Dr. Nelson. Again, we will be coming back to that, revisiting that with the audience, I'm sure. And let's move over to Dr. Harold Moore. Dr. Moore is you see the sign behind me, is a Morehouse man like yours truly. And Dr. Moore also is graduated from Morehouse School of Medicine. And we're just thankful that he's here. He's a family physician with the Emory Healthcare. And without any further ado, I'll turn it over to Dr. Moore. Dr. Moore, if you give us about 3 to 5 minutes of what you do as a family physician and how you've seen coronavirus COVID-19 play out in your practice.
Well, good evening, everyone, and thanks for having me on the panel, Mike. I really appreciate this opportunity to share my view of how my practice has been impacted. Here at Emory, we've had a pretty challenging, I guess, obstacle as far as trying to get patients in. We have sort of changed the dynamics of healthcare completely. We're not even seeing patients on a regular basis. In fact, we've actually gone to total video and teleconference medicine. Anything that's not urgent or emergent is not being seen in the office. So my day typically is telephone and video visits. Yesterday, I actually had to bring someone in who had some chest pain, but it turned out it was okay. But for the most part, the day has hit this, the coronavirus has impacted our practice tremendously. There were times when I was seeing 16, 18 patients a day, and now it dropped down to 4 to 5 a day. We've started the video medicine conference calls or telehealth medicine, and we're now able to book more patients, but people who need physical exams or annual wellness exams, they're not being seen at all until we get a handle on this virus. Still a lot of work to do, because in spite of that, we get, all of us are getting numerous calls. So we're getting a lot of calls that we have to answer. We're also having a lot of emails that we have to answer. So it seems like, even though my day doesn't seem busy with patients, as far as contact, I have a lot of paperwork and a lot of phone calls, a lot of emails to answer. So the day does get kind of eaten up just doing that. And ironically, I can't imagine how I was able to do this and see patients, because when I was doing this with patients, I still had to do all of this. But for the most part, it's transitioning a little better now. I think this coming week, we're sort of surveying our calendar and seeing how many patients we have for the following week. We give those patients a call, asking them if they want to do the telehealth via phone or if they want to do a video conference. And then we set that up with the patient. And a lot of my patients are receptive to it. Now, I've been in practice for about 30-some years, so I have a lot of 65 and older patients, and sometimes it tends to be a little challenging for them because they're not techie savvy, so getting on the phone and trying to do a Zoom video conference is a little difficult. So we started using Doximity this past week, and the Doximity application seems to be a lot easier. They just basically get a text message, they click on it, then we're up and going with the video. So that has worked out easier for me. Medications, we're doing e-scribes, so that's not a problem. I still don't do e-scribes with narcotics, so patients who need those still have to come in and pick them up. We do have that availability, but I chose not to do it because I want to keep a handle on those patients who are taking narcotics for pain management, because I do have a lot of patients that I manage with pain. But for the most part, it's worked out for me pretty well. And I think as time goes on, it'll get better. This probably will be the wave of the future. It's a little different, not being able to touch someone and listen to their heart and, and get the feeling of their emotions when you're seeing them. But it is what it is, and we just have to, adapt and adjust to it. And things should work out fine. But that's kind of how my work schedule has been going. If you had any other questions, I'd be glad to answer it later.
Well, again, Dr. Moore, we do want to thank you for those comments as well, those introductory comments. Wow, quite a bit this evening, as everyone has heard, hearing again sort of the approach to reproduction from obviously Dr. Nelson, and then hearing how, you know, telemedicine is probably going to be the wave of the future from Dr. Moore, and of course from Attorney Pick, you know, really the challenges that's, you know, with the LGBTQT community as far as the young people, and again, their increased possible suicide, or at least suicidal tendencies, especially during this period that our whole country is going through with this pandemic. So again, we do appreciate all of those introductory remarks, and we're at that point of the session again. You know, we started promptly at 7 and we're going to end promptly at 8, that we do want to open the floor to questions. As I mentioned at the beginning, if you have questions that you want to ask, just raise your hand and I can unmute you, or if you want to put questions in the chat, feel free to do that as well. And again, make them short because I don't want to be reading all evening here. So want to again open the floor to questions, and if anybody has a question, please either raise your hand or put the question in the chat, or if the panelists want to engage one another, feel free to do that as well. So any questions from anyone? Or panelists, do you have questions for each other? I think Attorney Pick looks like you had possibly a question for Dr. Nelson there.
I was interested by what Dr. Nelson had to say about, you know, the effect on patients of having to put off, you know, going down the road to conceiving a child. It's rather similar to what we've been hearing from youth who've been told that they have to delay any kind of transition-related care. So you have youth who were on hormones, for example, and they're being told not to go to the doctor to re-up those hormones because it's not, quote, necessary. Or you're having people who have saved up for years to have a transition surgery done and having that delayed off into the unknown for an extended period of time. I'm curious to know, how are you offering comfort to those patients and trying to, how can we offer comfort to folks that this will pass and that their medical hopes and dreams will still be possible?
As far as, am I muted? As far as as far as conception, a lot of women still remember, and I'm talking about just conception at this point, a lot of women are still have in the back of their minds, a lot of women remember the Zika virus that was relatively 18 months. You haven't heard it in the news that often recently. So in framing the delay, say, we just don't know how it's transmitted. We're not sure if people will develop immunity, and we really don't know if it's going to have an impact on early pregnancy. There's a couple of viruses that really have devastating impact and actually, you know, devastating. The child may not survive, or if it does, it'll have long-term complications like blindness, like mental retardation, like microcephaly. So when I say we just don't know, and if you can hold off until a little bit more information is available, then this is probably the most prudent way to, you know, proceed. So we just, I mean, you know, we take an oath to say first do no harm. So in actively trying to get somebody pregnant and they contract this disease and have some kind of long-term devastating complication would be terrible. So when I frame it that way and say, we're just, if you can hold on just a little bit until we get a little bit more information, or we I can give you a little bit more information so you can make a better informed decision, they understand that and they are in agreement with it because they're not going through all this. No one wants to have a handicapped or a challenged child or a damaged child, particularly if you are going through all of this extra steps to conceive. So I think in that regard, it's comforting.
Rania Abdullah, did you have your hand up? Did I see your hand? Oh, you did not have a question. Okay, I'm sorry. Anyone else with a question? You can also leave your questions in the chat. Dr. Moore, again, you mentioned a challenge that we're going to have, or what would possibly be the new norm. So how do we envision, again, these annual exams without there being that human touch there? How is that even going to be possible?
Can you hear me?
Yes.
Okay, that probably won't be an issue. I think in the light of the coronavirus, that's the only reason why wellness exams and physical exams are being kind of postponed. I suspect that you'll still need to have some contact when it comes to an actual physical exam, especially considering you got to check things like heart, lungs, those type of things, and you can't necessarily do it through technology right now. Now, there are some things out there that one can do with technology, even like taking EKGs, you can do that on some of these patients through the technology that's out there, but that would mean that that patient would have to have that device or that software to be able to do that. But I suspect that things like physical exams, annual wellness exams, you would definitely need to be seen by the physician, because to me, this is not the end of the doctor, I think
No.
we're gonna be around. You can't replace the mind and the body of the doctor with technology totally. I mean, so I don't think that would be an issue at all for the future.
Okay, wonderful.
Yeah, I'm just going to pipe up a little bit on, at Trevor, we deal with youth, we deal with folks who are, digital natives. They are used to being on phones and on screens.
Yes, absolutely.
But we're also very much aware right now that we're hearing from some youth who say that they've been sent home from school and they don't have access to computers to do their work on. So to the extent that the more you're relying on technology to connect with doctors, we know that that creates another barrier, especially for folks who have less financial means.
Mm-hmm.
So there's that concern that's involved with it. And also just at Trevor, we used to, for our Lifeline, that was based in call centers in New York and Los Angeles, actual physical call centers where you had a large number of staff and volunteers in one room. Obviously, that doesn't work out so well in the age of social distancing. So in the time period of about 2 weeks, we managed to take our system from being two physical call centers to allowing for complete remote staffing of having those counselors working from home. And I give all props to our tech team. They moved heaven and earth to make it possible. But because of that, we've also learned that there are a lot of challenges involved when you're trying to do any kind of care from a work from home scenario or a remote scenario. So there's a lot to be said, and I think you're absolutely right. The age of the doctor has not come to an end, and we're making do for now, but you want to be able to really get that human touch and that connection again. And I'll say this is doubly true for your LGBTQ patients who so often have reason to be skittish or fearful of the medical establishment, and that in-person relationship helps to develop trust.
Attorney Pick, for the young people that obviously the Trevor Project deals with, you were talking about the challenges that they're having during the social isolation period, that they're actually going into environments that could be very, very challenging. What's some resolve to that? How is it? The fact is they got to be under the same roof with individuals who have not accepted who they've become or who they are becoming. So how does the Trevor Project help these young people deal with that?
There are a couple of different ways. Part of it is offering advice on how to communicate clearly with the folks that they're living with. Mm-hmm. So some of that is just how to communicate and educate on, for example, for trans youth, this is my name, these are my pronouns, please use them. And to have that conversation respectfully. In other situations, our first advice is always, in the same way for doctors, it's first do no harms. It is, our advice to youth is first make sure you're safe. So some of that is, okay, sometimes you're just gonna need to find a space to be yourself, to connect with your affirming friends and connections. We're doing a lot of advice of, if they aren't reaching out to us directly at Trevor or connecting with other friends on something like Trevor's page, we're strongly encouraging things like, you know, watch parties of Netflix, do something to continue to virtually establish those same connections that support you when you're not in that home situation. But the reality is this is a very challenging time, and not just for LGBTQ youth. I mean, we're seeing spikes in domestic abuse calls to police and those other concerns that honestly, when you get people in a stressful situation and trap them under a roof, this is a tough time for a lot of folks. And we're definitely telling our youth to do what they have to take care of themselves.
Well, and quickly, thank you for that, Attorney Pick. If everyone could sort of put where they are right now, we'd like to sort of have some idea of where our participants are, you know, where they come from. So if you don't mind putting, you know, in the chat where you come from. Also, make sure if you want to be on the email list, make sure that you privately send me your email that you want to be notified whenever we have our EmPower Hour sessions, as well as when we put up these videos live on YouTube. So again, if you don't mind, just put in your city and your state, and we do appreciate that. Anyone with a question? Any other questions?
Mike, I'd just like to maybe hear or initiate a discussion on what Dr. Adams' comment, and then the Twitter storm afterwards about telling Black and brown people to step up and not go get your alcohol, your drugs, your smokes, and tell your do it for your abuela and your big mama and your pop. And I will tell you my opinion. I did take issue, not because of the big mama and abuela. I mean, I do know some people call their grandmother abuela. I know a lot of Black people. I don't know anybody who's called their grandmother big mama, but maybe they do. I don't know. At least Tyler Perry does. But I had issue with him. I understand he was trying to connect, and I think he was tasked with connecting with Black and brown people since we are disproportionately being affected. But I think all he had to do was say, go practice social distancing, do it for your grandparents, whatever you care to call them. But I had a little bit of issue of him saying, don't get your 40, your smokes and your weed, where he didn't say that to any other ethnic group. And certainly we know the opioid crisis is disproportionately affecting non-Black people. And I don't think Dr. Adams said, don't go get your heroin. So that was how I had issue with it. And I'm just wondering if anyone else on the panel had any, if they support what he said, neutral, or disagree with what he said, or how he said it.
And Dr. Nelson, as a point of clarification for those who don't know who Dr. Nelson is referring to, that is our United States Surgeon General, Dr. Jerome Adams, who made that comment. So that wasn't just Dr. Adams down the street. That is our Surgeon General who made those comments about, you know, again, weed, 40, and things of that nature. Smokes. That is our U.S. Surgeon General. Either of the panelists, Attorney Pick, Dr. Moore, either you want to comment on that? Dr. Moore?
Being that I didn't actually hear what he said, I don't really want to make a comment on it. I think at this point, you know, substance abuse, substance usage, and all of this is not a appropriate thing to consider during this time at all, because it's not sound and it's not healthy. So my issue would be to do things to prevent any harm to your body. So I have I don't support the thought at all, really. I just think that the best thing that all of us should do is take care of our temple. This is our body. We only have one of them, and we need to do the best that we can to keep it healthy. And that, to me, excludes things that might do harm to you.
Yeah, so much of what comes out of this administration is at best clumsy and at worst harmful. And I have to think that those remarks are both. And especially because as I noted earlier, the LGBTQ community of all races is, yes, we have a higher rate of smoking. We have a higher rate of HIV and cancer. And because a lot of it comes out of the same things, where I think what he was trying to get at is the people of color having some higher rates of the things that result in being immunocompromised that have a negative effect of this particular disease. But all of that doesn't have, it's not because of your race, or it's not because you're LGBTQ. A lot of that ties into poverty. A lot of that ties into discrimination. That ties into these other factors. And yes, the gay community is sometimes known for, you know, self-medicating to deal with the high level of stress that comes from being subject to discrimination. This is not uncommon, nor is that unique to us as a minority. But no matter what, telling people today to, you know, chastising them for using alcohol while currently under quarantine, that's not going to do a damn thing about the fact that some of our populations have greater health compromises because of living a hard life and facing a lot of challenges. So all you're doing is piling shame on and trying to make that into a stigma that's attached to this disease. That doesn't help anybody. Where right now, I'd much prefer Dr. Fauci's remarks, for saying that the data we're seeing about the death rates among particularly African Americans being higher because of this disease speaks to underlying societal pressures that are something our country really should work to address. And that includes things like eliminating discrimination and improving better access to healthcare.
But there's some other, I mean, as Dr. Moore probably can attest to, we do need to take some responsibility for a lot of our behaviors. However, I mean, if you look at the history of our country, where Black people, the government forced us to live in places that had environmentally, I mean, look what they did with Erin Brockovich. Those were poor, I mean, and that's some of what you were alluding to, poverty. Those were poor white people, and they didn't care about them. Look what they're doing in Flint. So they're, you know, poisoning our water, putting us in places that are toxic, like in Louisiana, like in Mississippi. You know, and maybe people have a distrust of the medical system because of Tuskegee. And so, I mean, we do have to take responsibility for our behaviors. However, we also need to separate this entrenched racism that's just so entrenched in our system that we don't even see it anymore. If you think about, so many laws in this country were based on racism, like the Electoral College, which is going to be really important in this upcoming election. That was to give Southern slave owners a little bit more power. So if we try to, I mean, I'm kind of not grateful, but trying to say, let's use this Corona crisis to really highlight this disparities. So it's the entrenched racism, and it's the punishment of being poor. And that's what, I guess that's why I felt like Dr. Adams' comments were just so disparaging, because it was telling poor people, again, you're being bad because you're poor, instead of saying, let's try to, you know, they were able to come up with trillions of dollars all of a sudden to give to everybody. We weren't able to do this before. So let's just use this crisis to highlight all the inequities and injustice that we have, you know, that we have in this country.
Right.
Absolutely, and it's intersectional, because
yeah.
I mean, absolutely, the population that I'm looking at that is suffering from massive housing insecurity right now is particularly your trans women of color.
Sure.
So where you have that combination and that intersection, and many of them are taking part in an economy where you're not getting unemployment for, say, your sex workers, for example. So they're like, when you see the intersections of where these various different places are, you're right, you're absolutely right. And I just hope that now that we're finally seeing some of the data, because one of the things we do at Trevor is we're trying to really encourage better data collection. And like, now that we're finally seeing, okay, this is what the data looks like on how COVID is affecting folks and how some communities are getting hit harder than others. there's a point of data, we don't collect the sexual orientation or gender identity data of somebody at their time of death. So like the work I do on suicide prevention, I can tell you statistics about suicide attempt rates based on sexual orientation or gender identity. We do not have data on how many LGBT folks complete suicide, because they're not allowed to tell us.
On the census?
Nope.
Oh.
The only way we show up on the census is, and this is the first sentence that's ever done it, we'll ask if you have a same-sex partner.
Okay.
So somebody like me, who is single, there's no way the census shows my orientation. It would only show up if I had a wife and was able to say, this is my same-sex wife.
Oh.
Wow.
And if you don't have data, you don't get policy.
And if I could, Dr. Ward has joined us by video. Speaking of data, she's really done some tremendous work in collecting data, as pertains to communities of color, specifically African Americans, because again, we know that there's just been a deluge of what's been happening to us with COVID-19. However, we hadn't had any reporting. And again, if Dr. Ward, if you don't mind, if you can share with us what you've been able to do in developing the dashboard and something that you're going to have up and running and available to the public soon. Dr. Ward.
Hi, can you hear me?
Yes.
Okay, well, thank you. I am loving this conversation. I really am happy that the conversation around sexual orientation and gender identity came up as it relates to the data, because there are so many marginalized communities that are not going to be reflected within the data. Even when you start thinking about just the idea of having some states who only will report Black, white, and other, no ethnicity, as if there is not enough concern about the data, but even to just think about data in that way is troubling as a public health professional. And I understand that I've gotten a lot of feedback about the data that I've been collecting as to why things are the way they are. And unfortunately, they come from people who are within those state institutions and working very hard to do this work. And I understand why they would want to be a bit defensive, but also give us explanation as to what we're seeing. But there's so much to this data that is not there. And I think that by following and tracking those states that are releasing data, I have 28 states so far. Yesterday, I did take a break that have reported race data of some type. Many of them do not report any multiple statistics. So they will only report about race at one touch point for an individual, meaning a person, if you think about it, they have to go get tested. They have to go to get tested. They are denied or accepted for testing. They then have to go, then they become a case. Then some of them end up in the hospital, and then some of them die. For the person who is recorded as a COVID death, we have at least 2 points for that person. And so what I'm concerned with is the quality of the data, the transparency, and that is really important for what we will do after this. We are not ahistorical. This stuff is actually documented in terms of the disparities with almost all of our previous situations of epidemics and pandemics. So really and truly, we should know by now we should have this down. We should have a model in place. And so hopefully, I'm really excited to hear what Case is doing in terms of having some understanding about transparency and data collection overall, because we really are at a point where it's one thing to say you're not, you didn't see it coming, but it's another when you talk about a system that is in place, every day that's not a pandemic. So if this is any sign of what's to come, we have a lot of work to do, and opportunity. I believe it is an opportunity for us to really step up and say this is unacceptable, and to think about those populations that are not being represented and reflected in this, because there are all these nuances and intersections of a person's identity, a person's experience that might be something that we need to look out for. And that is really grounded in health equity strategy.
And Dr. Ward, thank you so much for that. Again, if you could put your website up, so for those who want to, once Dr. Ward is able to get that information up and running on the dashboard. I'm sure if you access her website, that she'll have the information that would lead you to where that data will be mentioned and listed. And again, I do encourage you to use the chat area for networking. Again, if you have any websites, of course, Attorney Pick has left several articles there. Feel free to share the articles so that we can always refer to them for the information that we need, given our topic of coronavirus and COVID-19. Now, we're going to start coming to a close here, and I do want to allow the panelists a few minutes to give some closing remarks, and we'll do that in a few minutes. But what I do want to do is see if there's anybody else that has a question or a comment that they'd like to share from the audience. And if we don't see a hand or any question in the chat, we're going to go ahead and then allow the panelists to start making some closing comments. And again, we do thank everybody for being with us this evening, again, for the 4th installment of the EmPower Hour. So let's go ahead and start wrapping things up. It is 7:51. We're going to end promptly at 8 p.m. In this order, we're going to let Dr. Nelson go first, let Dr. Moore go second, and then we'll close things out with Attorney Pick, as our focus this evening, for the most part, has been on the LGBTQ community. And we do appreciate all of the perspectives that were shared, and hopefully everyone has become more empowered as a result of this evening. Dr. Nelson, closing comments, please.
As we continue to go through this crisis, I am just really excited and looking for the development of a vaccine. Usually it takes several years to get a vaccine developed. They're looking to have one available in 12 to 18 months, which is unprecedented. So I'm looking forward to see the outcomes of that. Looking to see if having had the having an infection, either mild or severe, if that is going to confer immunity. That's not really clear cut. Hopefully it will be. Another kind of novel way that people are being treated is to use the plasma for somebody who has been infected. Hopefully the antibodies that they've developed will be helpful to treating someone else. So looking forward to all of these outcomes. Of course, as far as pregnancy, I hope it's boring and nothing is exciting about the COVID virus with respect to pregnancy. And as far as the socio-political, like I kind of talked about before, hopefully this will shed a light on the disparities in healthcare. It's easy if you are part of the group that is less affected. If you have insurance and you live in a nice area and your water is clean and your environment is clean and you don't live in a food desert, you may not understand what it's like, but it's not really quite the great equalizer that's been touted, because it is disproportionately affecting some marginalized populations, but it has been detrimental enough to enough populations that maybe people can share some commonality, and the people who are a little bit more affluent or have a little bit more influence can make some positive change for those who don't.
Thank you, Dr. Nelson. Dr. Moore.
Well, can you hear me?
Yes.
Okay, good. I want to thank you, Mike, for putting together this conference. I think it's a wonderful idea. Definitely educating me a little bit about a lot of things that I wasn't aware of. I want to emphasize that, once again, that this is probably going to be a change in how medicine looks in the future. One thing I take away from this is that because of this coronavirus outbreak, it has opened my eyes up to the need for telehealth, particularly when you talk about underserved communities where there are no physicians that are readily available. So this is an opportunity that will allow us to reach out to those communities, to patients who can't actually get in. Now, of course, this has all been expedited because of the COVID-19 pandemic, allowing us to be able to do video telemedicine and teleconference medicine. But it is a wave of the future, and I think it's going to have a plus on the end. I'm hoping, and just like Dr. Nelson said, that we'll get this vaccine on board real soon. I'm also hoping that the general public will continue doing their social distancing, because we do not need to have everyone thinking that it's all over with and then all of a sudden we have a second wave of this virus. And I think this is going to be something that every governor of every state needs to really look at closely before they start saying, let's go back to business as usual. And on that note, I think that's the most important thing that we need to focus on, preventing this from becoming a second outbreak and protecting the community. That's the most important thing.
Thank you so much, Dr. Moore. Attorney Pitt, please. We have to,
Yeah.
Okay.
I think that business as usual is not going to be an option. I think that one way or the other, this has resulted in our society changing. And I think that we now have it on us to be intentional about what we want that change to look like. And I mean, there's the opportunity, we're all learning in the social distancing to take measures to be intentionally caring for the folks who are more vulnerable among us. We are, doing this so that our older folks, our immunocompromised folks, have a chance to get through. And I think that if we can adapt that and continue with that, and that'll involve things like using Dr. Ward's data collection, we can keep an eye towards our vulnerable populations and folks who've been left behind too many times before, or who are bearing the brunt of this disease too much right now. So let's allow that to be the thing that we take out of this. And some of that will be, I really hope to see, medical professionals making a intentional gesture to letting folks know, come to us, we will care for you, and we will care for you no matter who you are, so that we don't run into the problem of people being afraid to seek out the cure and that making the disease worse. So there are things that are in our society that we can make better. The diseases of discrimination, the disease of racism, of homophobia, of transphobia. And I hope that we can, as we try and fight COVID-19, we fight these other ailments as well.
Attorney Pitt, very great words to close us out this evening. Again, we want to thank everyone for being here, and we're not going to keep you that long. I do want to acknowledge a few people that I see here. Desmond Delk, Dr. Desmond Delk, PhD. He's professor at Langston University in Langston, Oklahoma. He's also a former student of mine at Morehouse, and just always great to see how he's gone from being a student, and now he's attained his PhD in kinesiology, and of course he's been on faculty there at Langston University for a few years now, and let's hope that he get tenured very soon. So Dr. Delk, we do appreciate you being here, and he's always supported us as well. Many of you know that I do a volunteer project every summer. Rania, who's here with us, Rania is one of our volunteers. Desmond is one of our volunteers. We take young people and we volunteer in different cities throughout the United States. Dr. Moore, Harold Moore, is one of our financial sponsors each year. So we do thank Dr. Moore for that. And again, both Desmond and Rania, they're financial sponsors as well as volunteers. So we do thank them for that so much. So with that, again, make sure that you contact one another. Websites have been left. Email addresses have been left. If you're not on the email list, please leave your email address down there so you can get communication from us, so you can find out when we're going to have the next EmPower Hour. We're not sure just yet. We're waiting for people to get back with us. But of course, this video will be uploaded within 24 hours, and then you'll have access to that. Again, we want to thank everybody for being here as we talk about coronavirus COVID-19. Again, we had some very enlightening information, as Dr. Moore said, on the LGBTQ community. Attorney Pitt, thank you so much. We learned so much from you this evening. We learned from all the panelists. This has been a wonderful session. Again, once we put the video up on YouTube, make sure that you pass it out to your network. Again, I'm here. I'm Mike Weaver. I serve as your host. I have a doctorate in public health. Started with an MPH back in '92 and received my DrPH in 2004. So again, it's just wonderful being here with you and leading you in this mission each and every time whenever we get together. Want to thank everyone for being here. If there are no other words, again, we're going to close as we always do, at least we try to do when we're not rushed, telling everyone to stay safe, stay healthy, and to stay at home. Until the next time, family, peace. Have a good evening. Bye.